Use of Codman paradox to perform safe and simple manipulation on anesthetic for release of contracture in frozen shoulder. The aims of this video is to describe the technique using the Codman paradox, to understand the biomechanical background for this technique, and to describe the results using this technique. Frozen shoulder has protracted course that may last 2 to 3 years. These have major implications on patients' function, satisfaction, and overall quality of life. This simple technique of manipulation under anesthetic may relieve pain and restore function quite immediately. In this technique, we utilize the Codman's paradox to achieve rotational movements in a controlled manner without creating rotational torque on the humerus, thus avoiding potential complications such as iatrogenic fractures. Codman's paradox refers to the movement occurring in the shoulder which is seemingly impossible. Paradox literally means a statement or proposition that seems self-contradictory or absurd, but in reality expresses a possible truth. Codman's paradox was described in 1934 and features the rotation of the arm around the shoulder without performing rotational movement. Codman proposed that a completely elevated humerus could be shown to be either in extreme external rotation or in extreme internal rotation without actually performing a distinct rotational movement. The paradox leads to an apparent 180-degree rotation in the shoulder when performing two sequential axial movements. The sequence of movement defines the rotational position of the shoulder either in external or internal rotation, as demonstrated in this drawing. Here we can see this volunteer demonstrating the Codman paradox. She performs two sequential axial movements, forward elevation to full elevation, and then bringing her arm to the sides. Once again, as she completes these two sequential axial movements, 180 degrees of rotation occurred in the shoulder without performing any distinct rotational movement. Her palms initially faced the thighs with the thumbs forward, are now facing outwards with the thumbs backwards. As she performs the same movements but in the opposite sequence, 180 degrees of rotation occurs with the palms facing outwards, but this time in internal rotation. The sequence of movements defines the rotational position of the shoulder, either external or internal rotation. We utilize this paradox of two sequential axial movements to achieve rotational movement in the shoulder as a safe manner to avoid any rotational torque on the humerus or the shoulder during manipulation and anesthesia, to achieve full range of movement and controlled tear of the capsule all around the glenoid. The manipulation technique. Initially, on examination anesthesia, there is global loss of range of movement. I put my hand in the patient's axilla and with the other hand stabilize the scapula. My forearm is against the patient's arm, thus having a very short lever arm. By bringing the arm to elevation in the plane of the scapula, we usually hear and feel a tearing sound where we tear the inferior capsule in the axillary fold. At that stage, the arm is in full elevation and full external rotation in abduction. Now we bring the arm that is in full external rotation down in abduction plane without any further rotation to tear the anterior capsule and achieve external rotation in adduction. Then we cross adduct to tear the posterior inferior capsule. And last, we hold the arm in internal rotation and cross adduct without any rotation to complete the tear of the posterior superior capsule. We achieved full range of movement in elevation, abduction, external rotation, and internal rotation. We haven't created any torque on the humerus, and this maneuver was performed with very short lever arm. Another case, once again, global stiffness on examination. Hand in the axilla, the other stabilizes the scapula. With very short lever arm elevation, the arm is now in full external rotation in abduction, and then bringing the arm down in the abduction plane to tear the anterior capsule. Then cross-body adduction to tear the posterior inferior capsule, and then with the shoulder in internal rotation, cross adduction without any rotation to complete the release. Full range of movement achieved. Full external rotation, full internal rotation, full elevation and abduction. We then inject the glenohumeral joint with 10 mL of 0.25% marcaine and 40 mg of depomedron. We try to aspirate the joint, and if we get blood from the joint, we know that this is due to the capsular tear, and we know that we are intra-articular. (210 patients with 214 shoulders with a mean age of 52.3 years underwent manipulation anesthetic using the Codman paradox for frozen shoulder between 2005 and 2013. 85 males, 125 females, 158 idiopathic, 31 diabetic, and 21 post-traumatic frozen shoulders. All were evaluated clinically, preoperatively, and postoperatively for pain, range of motion, constant score, patient satisfaction, and subjective shoulder value. The patients were reviewed at 3 weeks and 3 months post-manipulation. No complications were observed, no fractures, dislocations, or nerve injury encountered. We performed diagnostic arthroscopy in some patients that revealed torn thick capsule all around the glenoid. There were no rotator cuff tears or damage, no glenoid or humerus fractures, no labral injuries, and no nerve injuries. Unlike descriptions by other authors, using this technique of manipulation, we have not seen any complications. Results. At 3 weeks, significant improvement in constant score from 30.6 points preoperatively to 67.7 points postoperatively. The mean range of movement improved substantially, with forward elevation improving from 90.9 degrees to 151.7 degrees, abduction from 69 degrees to 146.5 degrees, internal rotation from 11.8 degrees to 62.4 degrees, and external rotation from 9.4 degrees to 47.6 degrees. Pain scores improved significantly from 4.5 to 9.7 out of 15. Patient satisfaction improved from 1.5 to 6.4 out of 10, and all of them were statistically significant. At 3 months, constant score rose to 73.7, the range of movement improved even further, the pain score improved to 10.4 out of 15, and patient satisfaction to 6.7 out of 10, all statistically significant. Discussion. The natural history of frozen shoulder remains controversial. Although it was thought that the majority of patients will eventually have complete resolution of disease, others report long-term pain and residual loss of motion. Schaffer and co-authors reported at a mean 7 years follow-up on 62 patients that 50% of the patients had still residual pain or loss of motion. Hand and co-authors at a mean follow-up of 4.4 years, range between 2 to 20 years, observed 41% of patients with some ongoing symptoms, pain, and functional loss. The importance of early recovery in frozen shoulder is crucial and ameliorates an individual's quality of life significantly. Furthermore, it accelerates return to work, thus shortens economic burden. Understanding Codman's paradox has enabled us to provide a safe, simple, and consistent method of manipulation anesthesia using short lever arm and avoiding perilous rotational torque with excellent short-term results. The outcome of this large consecutive series of patients with primary frozen shoulder treated with manipulation anesthesia utilizing Codman's paradox shows mean improvement of 36 points on the constant score at a follow-up of 3 weeks with no surgical complications. It allows 71% of the patients to return to work after 3 weeks and 79% after 3 months. Closed manipulation anesthesia have been used extensively with consistently satisfactory results in both short and long-term follow-up. However, complications have been reported: humeral and glenoid fractures, shoulder dislocations, post-manipulation pain, hemarthrosis, subscapularis rupture, labral tears, injury to the biceps tendon, tearing of the joint capsule, rotator cuff tears, traction injury to nerves about the shoulder. Lev and co-authors described arthroscopic findings of substantial soft tissue trauma following manipulation anesthetic. We report no complications as a result of the manipulation anesthesia in our study. There were no fracture or dislocations, no symptoms of acute rotator cuff tear, and no neurological or other iatrogenic injuries. There appear to be no short or long-term adverse clinical events in our patients. It is clear that not all the manipulation anesthesias are the same. The details and sequence of the technique are of prime importance. Our study includes the results of MUAs performed by the senior ortho as well as shoulder fellows and trainees. It is a safe and easily learned technique. This technique, if conducted properly, is safe, reproducible, and effective that provides rapid and excellent clinical results. To conclude, the use of Codman's paradox provides safe and efficient way to perform manipulation anesthesia for frozen shoulder. It results in dramatic early improvement in range of movement, functional outcomes, and high satisfaction as early as 3 weeks postoperatively.